So hello everyone and welcome to the 12 months progress report. I would like to introduce you to my PhD topic, Dentofacial Anomalies and Intervention Strategies. My name is Borbély Eszter. I'm a first year PhD student, a dentist, and as you can see my following team is Varga Gábor Ácslili and my SMS Laczko Dávid. My mission is setting the standard in dental anomaly management, and my mission is to implement evidence-based practices to address and correct dentofacial irregularities. I have two specific goals ongoing as of right now. The first one started in September, dealing with impacted canines, and the second one in November, dealing with maxillary protractions in maxillary hypoplasia. The title of my first topic is investigating the safety and efficacy of open versus closed surgical exposure of impacted maxillary canines, a systemic review and meta-analysis. Just a little bit about the background. An impacted tooth is one that fails to erupt into the dental arch within the developmental time frame. The maxillary canine is the second most commonly impacted tooth after the wisdom teeth. The prevalence of this is about 1 to 3.5% of the general population, which translates to about 78 to 273 million people worldwide. There are three main complications that I would like to mention. The first is functional issues. When we don't have the canine in the arch, we have problems with the occlusion and the bite, just like you see the house. When you're building a house, what is the most important element? The pillars. It is what hold the structural integrity and hold the overall harmony and balance of the house. Same thing with the canine. It's the same in the oral cavity. This leads to my second complication, which is the aesthetic concern. The teeth, as you can see, are a bit crooked all over the place and don't look like your typical natural Hollywood smile. This comes with the fact that it affects a person's smile, which leads to the third complication, which is the psychological impact, which is definitely affecting the self-esteem and confidence of children. So when we're treating these impacted canines, we have three treatment methods. The first is surgical exposure, which I will be getting into, transplantation, and extraction. These two are actually a lot more complicated and better to have the first, which is a surgical exposure. So let's get into it. The closed technique. The closed technique, as you can see in the picture, is a technique where they remove the gingiva and attach an orthodontic eyelet to the impacted tooth. They reclose the flap, they resuture it, and they wait for the forces to bring the tooth back into the arch. In the open, however, they remove the gingiva, they even remove the bone, and they leave this site open. They put a pack on it, sometimes for 10 days, and then attach the bond afterwards. That is why there's more pictures. So what is the problem actually with the closed technique? It is more technique sensitive. So you do have to open the flap, resuture the flap, and definitely more complicated. And it is more also difficult to direct the forces. So you don't see under the gingiva, and the tooth is simulating a normal eruption pathway, unlike in the open where there's nothing and it erupts easier. It does have increased treatment times, and the alignment times are then more unpredictable. However, in the closed technique, the infection rate is lower and the pain is said to be less. So the aim of this study is to actually evaluate and compare the clinical outcomes, the duration of the treatment phases, and the patient-reported experiences between these two techniques. Here's my clinical question. Does open surgical exposure reduce the treatment time, improve the periodontal health, compared to the closed technique for impacted canines? The population is adolescents with an impacted canine that are undergoing the surgical exposure. Intervention is the open technique, the compared as a closed technique, and the following outcomes were monitored. Main ones being treatment duration and surgery time. The clinical implication is establishing a treatment protocol to identify the safest and the most effective technique. The hypothesis is that open exposure of impacted maxillary canines shortens the treatment time and improves the periodontal health compared to the closed exposure. Here you can see my search key. The first one was about the population, and the second one about the intervention and the comparator. With our flowchart selection, we had a total of 54 eligible articles for full text. This is the progress of my first project. We have about 90% of the plots received, 10 more to go, And currently I started writing the method section of the manuscript. So here's my first figure. This talks about the mean difference in surgical exposure time measured in minutes for the bilateral canine impaction. This is when there are 2 canines impacted, not just one. We had 3 studies. We had non-randomized and randomized control studies looked at. We had a population of about 80 patients and a pretty high heterogeneity. This could be the case of the different surgeons, the different facilities. But however, in overall, we had a difference of 12 minutes. So the open technique was 12 minutes shorter than in the closed technique surgeries. This 12 minutes is not statistically significant. However, it is clinically very significant because we all know that in a very busy dental clinic, 12 minutes can mean a lot. In my second figure, I would like to show the mean differences in the night of post-operation pain for the canine impactions. This was a patient-reported outcome, so they were all asked a questionnaire to fill out how their pain was on a VAS scale, as I mentioned. Here we had 5 studies, also again randomized and non-randomized studies. The heterogeneity was mild, and as we can see on the 4 studies, the pain didn't really differ between the open and the closed. However, in the last article from Bjorksved, we see that it is very far on one side. So to summarize this, we cannot actually make a fully statement whether this one is lower or in that it's lower. However, we do need to find more research or see if there are any more data supporting that outlier or, yeah. In the third figure, this is a bit later on. So this is the 7-day post-op operation of the pain. This would also use the VAS scale. We also had non-randomized and randomized control studies here also. And we had about 223 patients. And in this chart, we can also see that it's not statistically significant or clinically, because if we have these 3 studies, I think it's actually not enough data to fully conclude whether or not. But in the 7 days, we see that the pain is lower in the closed. And this is most likely because in the open technique, as I mentioned in the background, we are leaving that flap we're leaving the flap exposed, and the recovery is a bit more painful. With that, I would quickly get into my second topic, which is evaluating the efficacy of tooth-borne versus bone-borne maxillary protections in maxillary hypoplasia. This will also be a systemic review and meta-analysis. In short, maxillary hypoplasia is an underdevelopment of the maxilla. This happens in skeletal class 3 malocclusions. The pictures are there to show the concave facial profile, and as we can see, malocclusion, which are actual functional issues, which also leads to speech difficulties and a compromised aesthetic. We cannot see the midface, but it also has a midface deficiency. There are 2 techniques as of now to fix this issue. The tooth-borne, which has been used for a very long time, and now the bone-borne. The tooth-borne, in short, applies external orthopedic forces to protect the maxilla. This is a Delaire mask that is used with this treatment. It is not aesthetically pleasing, and children actually do not like wearing it, so the limitation is definitely of patient compliance. However, the other one is that we have risks of undesired dental compensations. So we are relying on the actual tooth to make this movement to bring the complete maxilla forward. However, with the bone-borne, we have the maxillary protections. Here we use a skeletal anchorage system, so like mini pins and implants, which are implemented into the bone. And actually, we are minimizing these compensations, and we don't rely on external forces. And the aim of the study will be to see if we can actually change the bone-borne with the tooth-borne. Here's my question. Can the bone-borne therapies replace the conventional tooth-borne methods? We are still looking at the same population, so adolescents, and the outcomes of these orthodontic measures. And the implication is to find, again, the most effective technique. Here you can see my 4 key articles, and they all have the same intervention and comparator. We plan to submit the first project now and the next one in 2026 of June. And with that, I would quickly close my presentation. The only way to do great work is to love what you do, by Steve Jobs. Thank you for your kind attention.
Congratulations. I have a question about your second project, just more of like a theoretical, like patient-focused one. So it would be, like, this is more of a comment, but like maybe it would be worth exploring like the patient response to like exchanging the masks to the bone-borne like option. So like it would be interesting to see how patients and their parents react to this option, because I was talking to a patient like a few months ago, and they seemed very concerned about the just the option of treatment of having something drilled into their jawbones. So yeah, that would be an interesting point to explore as well.
Thank you for your recommendation. I'll keep that in mind.
I am just curious that in your first study, this is the most important outcome, that your primary outcome, that usually studies decide that technique effective or not if we investigate the time.
Well, not necessarily. So the time of the treatment is more outcome, and also the periodontal parameters. The periodontal one we're still waiting on from the statisticians, so I wasn't able to bring that. But definitely, I personally think that in the study, the periodontal parameters and the overall healing of that is a lot more important, and also the treatment time. So how long it's going to take for them to wear, or how long it's going to take, sorry, for the impacted canine to come into the arch, and the treatment, I think, is also a bit more relevant. The surgery time is just also important, but not the most important, especially from the patient's standpoint.
Now, I may have a question regarding your first study in figure 2. I mean, you've sounded quite a bit disappointed when you compared the postoperative pain between the open and closed. Did you assume something else regarding these two type of techniques?
Actually, so a lot of studies, or not a lot, basically there are studies like this one, which says that it is lower in the closed. And then there are those 4 studies, and there were other studies which we had to actually exclude, but they also gave bunch of different results. So I was not disappointed, I didn't have any expectations, but it's just a bit confusing, because one says this, the other one says that, and there's no...
Did you consider about the reason?
What I can only think about is that pain is definitely a personal feeling. So my scale worthy of my pain after a surgery might not reflect the same as someone else's opinion on that same scale. So
these publications apply the same, I mean, like questionnaire or form, or it was just like...
The questions are very similar, yes.
No, very
yes,
similar.
yes, yes.
All right.